prepare him for transplantation. So at the end, I would like to thank you for your attention, and I would like to thank all the members, all my professors and colleagues at the Pediatric Allergy, Immunology and Rheumatology team. This unit was founded by our beloved Professor Yahya Al-Gamal, Allah yarhamu wa yahsin ilayh. We lost him this year, but إن شاء الله إن شاء الله إن شاء الله كل حاجة كويسة من الوحدة دي في ميزان حسناته إن شاء الله. ربنا يرحمه ويحسن إليه ويقدرنا نعمل كل حاجة كويسة نستمر فيها. Thank you, and any questions are more than welcome. Thank you so much.
احنا بنشكرك جدا يا داليا على البرزنتيشن الجميلة اللي قدمتيها، وطبعا احنا يعني كلنا الوحدة بتاعتنا يعني مفتقدين الأستاذ الكبير ومؤسس الوحدة ومعلم كل الأجيال أستاذنا الأستاذ الدكتور يحيى الجمل. احنا لغايه دلوقتي الواحد بصراحه عشان اقول لكم الحق في حاله لسه، يعني طبعا الموت علينا حق كل حاجه، انما يعني لسه في حاله كده، يعني مش عايزه اقول دينايل، انما اقول يعني لسه مش مصدقين الواقع اللي احنا موجودين فيه. بس احنا يعني بندعي له طول الوقت، ويعني انا حاسه ان هو هيكون معانا النهارده ويكون فخور بيكم، لان هو ما عمل الوحده دي عملها، وكان كل هدفه التعليم وانه يعلم الاجيال وان تستمر المسيره اللي هو بدأها. ويا رب يا رب يقدرنا كلنا ان احنا نستمر في مسيره العطاء اللي احنا فيها، والتعليم الطبي المستمر وخدمه المرضى، ويكون أستاذنا كده حاسس بينا وعارف إن إحنا يعني الحمد لله بنكمل المسيرة، وإن هو كل اللي علمه لنا وكل المجهود اللي عمله في تعليمنا يكون في ميزان حسناته، ويكون ما راحش هدر، لأنه طبعا العلم اللي ينتفع به بيبقى دايما خالد مدى الدهر. شكرا ليكي يا داليا.
شكرا لحضرتك يا دكتور شيرين، ربنا يديكي الصحة يا رب.
ربنا يخليكي حبيبتي، واتمنى يكون كل اللي معانا في الويبينار دلوقتي يكونوا يعني استمتعوا زيي بالبرزنتيشن بتاعتك جميله. وهننتقل دلوقتي لاستاذه الدكتوره رشا حسن، هي تتولى بقى الجزء الثاني اللي هو في الحالات
ان شاء الله. تمام. شكرا دكتوره داليا، شكرا دكتوره شيرين. احنا دلوقتي الجزء الجاي عندنا اللي هو هنعرض فيه البيشنت ستوريز والكومنت عليها مع اخواتي الاعزاء دكتوره غاده ودكتوره ربا. فهنعرض اول حاله بيشنت ستوري هتقولها لنا والده بيشنت with Agammaglobulinemia. هنعرض الفيديو دلوقتي. السلام عليكم يا والده محمد، هل حضراتكم شايفين الفيديو؟ طيب اطمن الاول.
كويس قوي يا دكتور.
شايفينه جميل.
ممكن تحكي لنا قصه محمد سنه قد ايه دلوقتي؟
محمد سنه دلوقتي 3 سنين.
تمام. القصه بدات من امتى؟
القصه بدات تقريبا ان هو عنده 6 شهور، كان دايما بيجيله التهابات رئويه ونزلات معويه مستمره. فكنت دايما بوديه للدكاتره بره وبيدوني العلاج اللي هو الالتهاب الرئوي، ويعني كان النزلات بتتحسن شويه، بس صدره طبعا كان دايما في صوت عالي ما بيتحسنش. فكان حتى العلاج اللي كانوا بيدوله لما كانوا يديله العلاج الدواء ما كانش بيجيب معاه نتيجه،
اللي بالفم ما كانش بيجيب نتيجه،
لازم المضاد الحيوي الحقن. لغايه لما تم على الحال ده تقريبا 2 سنين. فجيت هنا المستشفى وحجزوني، وبعدين سالوني على يعني اذا كان في حد في العيله دايما بيتعب او كده. فانا كان دايما يعني انا كان لي 4 ولاد سنهم من 1.5 سنة ل2 كان يجي لهم التهاب رئوي وبيموتوا بيه.
دول اخواتك؟
دول اخواتي.
تمام.
وليا ابن خالتي مريض مناعه، فهم شكوا ان ممكن يكون محمد برضو مرضه مناعي. فطلبوا مننا تحاليل المناعه عملناها وطلع عنده نقص في الاجسام المناعيه. ومن ساعتها هم بيديروا بقى علاج اللي هو الاجسام المضاده دوت، والحمد لله من ساعتها ماشي كويس. يعني النزلات قلت والالتهابات الرئويه قلت كتير على الاول.
الحمد لله. طيب كنا عايزين نسالك على موضوع التطعيمات، هل في عندنا اي مشاكل مع التطعيمات؟
وديت له تطعيماته كلها، كان خدها طبعا قبل ما يتشخص. وكان وديت له تطعيمات اللي هي شلل الاطفال، بس انا ما كنتش اعرف ان هي فيها مشكله، بس من ساعه ما خدها تعب جدا. وجيت اتحجزت بسببها هنا في المستشفى، وعادوا له الجرعه اللي كان بياخدها، والحمد لله يعني.
تعب في شكل ايه؟
نعم.
تعب في شكل ايه؟
تعب، كان صدره برضو صوته عالي خالص، وسخونيه واسهال.
تمام. كان عندنا
كان في ترجيع برضو.
كان عندنا اي مشكله في الحركه او درجه الوعي؟
لا.
طيب الحمد لله. شكرا يا والدة محمد.
شكرا.
طيب ده كان الفيديو ل one of our patients. دكتورة غادة شوشة مشكورة هتكومنت على الكيس معانا. دكتورة غادة.
هي الدكتورة غادة كانت معانا دلوقتي، أنا لسه شايفاها. اللي هي خرجت
غالبا عاملة ميوت للميكروفون بتاعها.
هنتأكد. اهي دكتورة غادة معانا.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته. يا غادة اتفضلي.
اللي حصل ده. طيب. Today we will talk about Agammaglobulinemia as an example of predominantly deficient antibodies, one of the major primary immune deficiencies. We will talk about the definition of Agammaglobulinemia, a tale of a disease. زي ما مامة الولد اللي شفناه من شوية حكت لنا القصة بتاعته. هنتكلم what we have from the 10 warning signs, location on the map of primary immune deficiency, modalities of treatment, and the dilemma of vaccination. ايه اللي ينفع يتاخد وايه اللي ما ينفعش يتاخد. أول حاجة هي القصة بدأت بولد كويس قوي. He was born normal. And then at the age of 6 to 9 months, he started to develop recurrent infections in the form of sinopulmonary infections, respiratory infections, recurrent seborrheic otitis media, recurrent gastrointestinal infections, may be present with meningitis, may be arthritis, may be skin infections like pyoderma or cellulitis, whatever. The infections are mainly related to bacterial infections, mainly capsulated infections like Staph aureus, pneumococci, meningococci, Haemophilus influenzae, etc. If he neglected, like the patient, we have seen his video, if he neglected, he will lose his weight gradually. The predominant feature of these patients that they have absent lymphoid tissue. We cannot find tonsils or adenoids at those patients. What's Agammaglobulinemia? It's an X-linked recessive primary immune deficiency, one of the common immune deficiencies, characterized by absence of all immunoglobulins in addition to absence of pre-B cells, mainly the CD19 positive B lymphocytes. It's named Bruton disease. Why? Because the main defect here is the Bruton tyrosine kinase enzyme, which is responsible for the differentiation and maturation of pro-B cells into pre-B cells, and then the production of mature B cells, which are responsible for producing significant and specific immunoglobulins, which are known as immunoglobulin IgM, IgG, IgA, and the specific forms against different infections or organisms. The majority of patients are X-linked recessive. As we know, the X-linked recessive inheritance is mainly manifesting in the boys, and the females are carriers. So we have here an infected male, and his mother and sister are carriers. So when we ask about the family history, we should be concerned about the maternal uncles and the male cousins of the maternal side. And we should investigate and screen all the other siblings, either males or females, to search for other diseased or diseased male siblings, but still asymptomatic, or carrier sisters. However, some patients are autosomal recessive in their inheritance, but in this form of Agammaglobulinemia, the enzyme defect or the mutation is not related to the Bruton tyrosine kinase, but related to the receptors around the B cells, like the IgM heavy chain or the light chains or the immunoglobulin receptor associated signal transducing class IgA and IgB, or cytoplasmic adapted molecule B cell linker protein. In very rare occasions, autosomal dominant agammaglobulinemia is detected and is related to monogenic defect in the transcription factor 3. The clinical presentation of both the X-linked recessive phenotype and the autosomal recessive phenotype are almost the same. Both of them have paucity of lymphoid tissue. Both of them have profound decrease in deficiency of all the immunoglobulins and the B cells. The T cells are normal both in function and number. No risk of autoimmune complications in most of the cases, and some of them present with neutropenia. When the patient is neglected or delayed in his diagnosis, they might present to us in a very late case or a complication like chronic lung disease or bronchiectasis. So where we are from the 10 warning signs, how I can pick this patient in the early start of his manifestations and to refer him to a specialist. Here we have recurrent otitis media, separative otitis media. We can have recurrent serious sinusitis. Those patients can have recurrent pneumonias. They might not respond to oral antibiotics and need parenteral antibiotics. The oral antibiotics for prolonged durations may not be efficient, and family history is positive in most of them. Recurrent fungal infections are not that common, and abscesses are not as well common in those patients. So we have more than 2 signs of the 10 warning signs in patients with agammaglobulinemia. Look here at this chart. About 68% of the infections of the patients have respiratory infections, and almost 50% of them have gastrointestinal infections, and joint manifestations are present in 44%, otitis media, separative otitis media in 42%, and meningoencephalitis as well as skin infections are present in 25% for each. Where are we on the map of PID? As we said, agammaglobulinemia is one of the predominantly deficient antibody defects, and those represent 65% of all the primary immune deficiencies. When we have a patient fulfilling the criteria of immune deficiency according to the 10 warning signs, and we did for him the immunoglobulins, and we found low serum IgG, so we should screen for the other immunoglobulins. If we find low serum IgM and IgA, we are left with the B lymphocytes to be assessed. If they are less than 1%, so we are here with agammaglobulinemia. However, it's X-linked or autosomal recessive according to the gene mutation that's found in the patient. What are the modalities of treatment? The main line of treatment is intravenous immunoglobulins. If the patient is coming with serious infection, serious pneumonia, septicemia, meningitis, whatsoever, we should give loading dose or high dose of IVIG, which is 1 to 2 grams per kg per dose. But if the patient is presenting with mild to moderate infection, he will start the typical dose of IVIG, which is 0.4 to 0.6 grams per kg per dose, to be given every 3 to 4 weeks according to the condition of the patient himself, adjusted according to his general condition, to his seriousness of infections, to the frequency of infections, and as well according to the trough level of immunoglobulin G, which should be kept about 500 to 800 milligram per deciliter. Antibiotics should be given during the time of infection. Parenteral antibiotics have the priority, particularly the broad spectrum antibiotics like the penicillins and ceftriaxones, the penicillins and the other broad spectrum antibiotics, because the most common infections, as we said, are the sinopulmonary infections. Some patients need prophylactic doses of antibiotics in between the intervals between the IVIG doses. Hematopoietic stem cell transplantation is suitable for some patients, but not for all the patients. It's for sure not suitable for those who have delayed conditions, or those who come with bronchiectasis, chronic lung diseases, or those who have severe failure to thrive. The hematopoietic stem cell transplantation is not fit for them, and it needs a good cross-matching between the patient and one of his, it's better to be one of his first-degree relatives. Screening for the other family members is very mandatory, especially for the siblings and the maternal uncles and maternal cousins. we start screening doing the immunoglobulins at first, and those who have deficient immunoglobulins will be screened for the B cells. What about the dilemma of vaccinations? Some vaccines are mandatory to be given. As we said, they are born for the encapsulated bacterial infections. So polyclonal pneumococcal vaccine and the polysaccharide meningococcal vaccines are highly recommended to be given. And on the other hand, all the live attenuated vaccines are contraindicated for those patients, not only for the patients, but also for any siblings or other children in the household. Why? Because the child himself might be infected, and in case of oral polio vaccine, the patient, the immune deficient patient, may shed the living virus in his stools for months or years. So he would be carrier for the living vaccine, for the living virus. Okay, what should we do if the patient accidentally received one of the live attenuated vaccines, like the oral polio vaccine? We should obtain a stool culture immediately to check for the passage of the attenuated vaccine, and we should give an extra dose of IVIG to maintain the immunoglobulin level above 500. The first one here is the sapien, or the oral polio vaccine. It should not be given to any immune deficient patient at any occasion or any of his siblings. The second one is the intramuscular or inactivated polio vaccine, the SOC vaccine, which is now mandatory at the age of 4 months. At the end, I'd like to thank all my professors and colleagues, the pioneers of pediatric allergy, immunology, and rheumatology, who taught us everything. They are the real backbone, they are the real family and support. Thank you.
شكرا جزيلا دكتورة غادة على ال very comprehensive, clear and to the point lecture. دكتورة غادة is a very hardworking and an eminent member of the Pediatric Allergy Immunology Unit في Ain Shams University, و her efforts are known everywhere. شكرا دكتورة غادة.
شكرا جزيلا دكتورة